An exciting new field, biofeedback in psychotherapy, the subject of this week's edition of Audio Digest Psychiatry, Volume 4, Number 10, for the week of May 26, 1975. What is biofeedback, and how does it work? A pioneer in the research field, the Menninger Clinic's Elmer Green, explains it this way.
Biofeedback, the way we're thinking of it anyway, is the feedback of biological information to a person, and that's essentially all it is. If you stand on a bathroom scale and you look at your weight in the little window, that is biofeedback, period. And that's all it is, just the feedback of information about something about you in the biological domain. If you do anything about it, like going on a diet, and you use the scale to tell you what you're doing, then I suppose we could call that biofeedback training. A little bit long term. It's a lot longer term than looking at a thermometer to see whether or not you can raise your temperature of your hand. But still it would be a kind of biofeedback training. By means of a sensitive pickup, getting the information on a polygraph and feeding back the information on a meter so that it comes visually back and of course goes into the cortex. In some way it completes the biocybernetic loop that makes it possible for the person to get the muscle tension under control. What surprised us was that not only were we getting single motor unit firing, which means one nerve firing in a nerve group, and of course firing the muscle fibers connected to that one nerve fiber. Not only that, every once in a while one of the students that we were working with would drop down to total muscular zero, below the level of just the normal tone of the muscle, implying or indicating that the person not only could turn off the positive activity but also could inhibit the normal spontaneous firing. But that is biofeedback. Well, the thing that to us is interesting about it is the rationale. Now, I want to talk about this rationale because I think that it's important to consider the fact that all of the things that we are talking about in the physiological domain have been known for a long time, maybe since 1937 or before that by a lot of people, but it's been rather ignored. And when we first began talking about, well, what's going on inside there in the Biofeedback Research Society, people were saying, nobody knows what's going on in there. And that turned out to be a huge handicap. The doctors that we were working with believed that, and the patients thought that too. And the result was that then the cortex, if I can talk in that metaphorical way, not having anything to do, raised havoc. Because it was saying all the time, nobody knows what's going on in there, and as a matter of fact, maybe nothing is going on in there. So we finally decided it was necessary to look into what actually was happening. And the thing is relatively simple. This is pretty much right out of the literature.
As Dr. Green explains the rationale of biofeedback, refer to your table of contents, Doctor, for a visual description of the mechanism involved.
I divided the diagram with a horizontal line into an upper and lower part. And the upper part I call the normally conscious voluntary domain cortical and craniospinal. Okay, now this is what I'd call a rough indication of the way it is. And down at the bottom it's the normally unconscious involuntary domain subcortical and autonomic. So that we have unconscious and involuntary neurological processes in the bottom half and conscious voluntary processes in the upper half. Now I mixed the psychological words and the neurological words, and partly on purpose, and that is I'm not sure anymore that we can separate those words. If we say involuntary, we can say unconscious, and if we say unconscious, we can say involuntary. Even though one is neurological and the other is psychological, I think that it's necessary for us to start using them a little bit more interchangeably. If information comes to us from outside the skin, and the top box on the left says sensory perception of outside the skin, OUTS, events. If someone calls up on the phone and gives a message, the person who gets the message may be happy or sad or may not have any particular reaction, but nevertheless, there is an emotional response of some kind, and a mental response to this information. The information coming down this arrow comes to this box down here, which I've called emotional and mental response to OUTS, outside the skin, events. Now, the box is on the center line because, well, we know that we're conscious of part of the response, but a lot of the response we're not conscious of. So the box is divided into the conscious section and the unconscious section. Whether it should be in the middle or not, I don't know. Maybe for some people it ought to be all in the unconscious, and for others be almost all in the conscious. But in any event, it indicates that there is an unconscious component. The fascinating thing about this is that the emotional response is reflected in the limbic system. Hundreds of reports now, since 1937, when Papes first outlined his idea of the autonomic and limbic responder to the emotional things in life, and he outlined his theoretical position. Since then, hundreds of papers have been written and hundreds of research studies have been conducted showing that there is a limbic response connected with every emotional response. As far as anyone can tell, there aren't any exceptions to it. If you put the electrode in the right place, I suppose you could say, I didn't get anything. But in any event, it appears that there always is some sort of an electrical change in the neurological behavior of the limbic system whenever there's an emotional response of some kind. You remember Masterman's work, which he reported back in 1941 with cats, with depth electrodes implanted in cat brains down in the hypothalamic, septal, and limbic areas. And if he would press the button and stimulate with spikes, he would get sometimes rages. He called these rages sham rages because if you quit pressing the button and quit stimulating, the cat would recover instantly. If you press the button, the claws would come out, the hair would stand on end, the cat's whiskers would stick out, and he'd start spitting and snarling. Take his finger off the button, and the claws would go back in. You could pet the cat, and it would start purring. So he called it a sham rage. But Heath and his group down at Tulane now have done a lot of the same kinds of studies with human beings, in which they were doing exploratory work with depth electrodes to find and delineate the boundaries of tumors in the brain. And since he'd stimulate to see whether or not they were getting any psychological or physiological changes in the body and use that as an exploration device. They noticed the same thing that Masterman and the others have noticed in animals, and that is that if you stimulate in certain areas, human beings were getting responses that were either making them angry or happy or sad or feeling various moods. And this was in response to electrical changes induced into the limbic system and other pieces of the subcortical brain. So if you put electricity in, you get emotional changes out. But if you do exactly the opposite, if you somehow induce an emotional state, like you say to the person, well, tell me about your big problem today. And that would cause enough of an emotional response so they start getting electrical changes out. In other words, it works both ways. You put electricity in, you get emotional changes out. If you put emotional changes in, you get electrical changes out. In other words, I'm not going to say it's a black box, but at least there's a transfer function so that the emotional states are reflected in the lower brain. And a lot of it is not only subcortical, it's unconscious. And interestingly enough, the limbic system is connected by a large number of pathways to the hypothalamic, which is, even though it weighs only about 4 grams, is a control center for almost all of the unconscious processes of the body. It controls blood flow throughout the body, temperature of the body, visceral processes. Incidentally, McLean at NIMH called the limbic system the visceral brain, and somebody else has called it the emotional brain. And yet, it's hooked to the hypothalamus, and it drives the hypothalamus. A lot of the circuits in the hypothalamus are purely homeostatic in the sense that, well, I suppose we could say they're all homeostatic, in that our temperature is self-regulated, blood pressure generally is self-regulated, blood flow is self-regulated. We don't have to consciously do anything about it. But here it is, it's hooked to the limbic system. So if you induce an emotional change, you get a limbic change, and you can get a hypothalamic change. And that changes the homeostatic balance point of this normally automatic system. Below the hypothalamic, of course, is hanging the pituitary, which is half neurological and half hormonal, and it's a slave mechanism to the structures in the brain just above it. And since it's at the top of the hormonal hierarchy, and the other glandular systems in the body get instructions to some extent from the pituitary, it's easy to see how information coming in from a telephone call, coming down through emotional, mental responses, limbic responses, hypothalamic, pituitary responses, end up as physiological responses. Okay, everybody knows this. This is what everybody's thoroughly researched in the neurological area since the 30s. What wasn't known was the fact that if you pick up any of this physiological information with a sensitive electronic detector and feed it back so that you end up with sensory perception of inside the skin, INS events, if you feed it back on a meter or something, then the person has he sees it, and this is of course in the objective domain now because it's outside the skin, he sees it and he has an emotional response. And so here's another emotional and mental response, but this time it's to inside the skin events. And that causes a new limbic response, and that causes a new hypothalamic response, a new physiological response, and the meter moves. Okay, if the person likes what's going on, then the meter will go one way, and if the person doesn't like what's going on, the meter has a tendency to go the other way. I'll give you an example. I was working with a lady who didn't believe in all this stuff. She says, you can't control temperature. She says that, and besides, that's spooky. And I said, well, it may be spooky, but you can do it anyway. And she says, oh, well, that won't work with me. I can't do any of that kind of stuff. And I said, well, that's all right. Just wire up and we'll see what we can do. So we wired it up and we began the autogenic phrase. And the temperature began dropping. And within about 2 minutes, it had dropped 7 degrees Fahrenheit. And I stopped and I said, wow, you really have control. Congratulations. And she says, what are you talking about? It went the wrong way. And I says, oh yeah, well, who cares which way it went? You got the control, and not only that, you predicted it. You said that you couldn't do it, and not only that, you proved it. And so then the dilemma was hers, because she had to figure out what to think about that. I said, you really got it. And so then she thought, well, maybe I can do it. And so then she really tried, and the temperature dropped another 5 degrees. And then she says, oh, well, okay, so it responded, but I can't do it. I give up. I'm a loser anyway. And then as soon as she said that, I give up. Then the temperature started going up. And I said, okay, that's lesson number 2, give up. And she got very excited. It started rising very fast, and she got very happy. And she said, look at that, it's going up, it's going up. And as soon as she said that, it started going down. And I said to her, that's lesson number 3. Keep your cool. You can't get too happy and you can't get too sad. You have to stay in the middle. You have to be a little bit detached. And finally she learned how to raise her temperature. But it's sort of an example of what is happening, because the blood flow in the hands is controlled by, or the temperature is controlled by blood flow. Blood flow is controlled, of course, by the blood vessels. The diameter of the blood vessels has a lot to do with how much blood there is in the hands, of course, and that diameter is controlled by smooth muscles and blood vessel walls, and those smooth muscles are activated in the peripheral parts of the body only by the sympathetic section of the autonomic nervous system. So that the temperature is a one variable indicator of what's going on in the fight or flight machinery, the activation part of the autonomic nervous system. That's great. A one variable indicator of what the sympathetic nervous system is doing. And so when she was tense, that was sympathetic activation, and it closed off blood flow in the hands, and her hands got cold. And when she gave up and relaxed, then that was sympathetic turnoff, and the blood vessels dilated, and her hands got warmer. And then when she got so happy, that was activation, and that constricted the blood vessels, and they started cooling again. Well, it's that kind of demonstration that convinces the people who work with this that it really works. The interesting thing about this feedback loop is the fact that this is mathematically the way in which everything is constructed, either by humans or in nature, that's automatic. You have to have feedback. As far as I know, and I haven't found any exceptions to this, everything that was ever learned was learned with feedback of some kind, and nothing that was learned without feedback. If you're learning to drive a car, you get in the car and you have to have feedback. That is, you have to look out the window to see what's going on. If you're teaching somebody to play a pinball machine, blindfolded, you have a problem. They can still hear what's going on. But if they couldn't sense any vibrations and they couldn't hear what was going on and they couldn't see what was going on, they probably wouldn't be able to learn. What we're saying about biofeedback is, well, biofeedback is like taking the blindfold off. Well, I think that I better stop right here and start talking about the training program and the thermometers. Now, what I'm going to suggest is you put the thermometer on your finger and tape it to your finger so that you can read it on the palm of your hand. Don't want to tape it so tight that you have problems with blood flow. While your temperature is equalizing there, I'm going to say a couple of words about Johannes Schultz. About 1910, Johannes Schultz was working with hypnosis, and he noticed that his good hypnotic subjects were reporting a feeling of heaviness and warmth. And at about the time that Freud gave up hypnosis because it seemed to be an undependable medical tool, Schultz was thinking, the reason it's undependable is because we're not turning the responsibility for this regulation over to the patient. And he began then autogenic, self-generated, self-motivated training. And he decided that the thing to do would let the patient induce a feeling of heaviness in the body and a feeling of warmth in the hands, and then go into the problems that should be solved. And we found out, with working now with lots of patients, and you'll hear more about this, that this state of quietness, the state of relaxation, precedes the body taking instructions. If you want to tell your stomach what to do, it doesn't listen. unless first you're very quiet. That doesn't mean your stomach is necessarily quiet, but you have to get into this feeling of heaviness and warmth. Now, some people will report lightness and warmth, but that doesn't make any difference. But it's still a body image change. It's a state of quiet body. If the body begins to be quiet, it starts listening. Well, Schultz reported this, but not much research was done, and that was why in 1964, when we got to the Menninger Foundation, we decided, my wife and I decided, that it would be interesting to try to verify what Schultz had already said. And we tried it with temperature, and we got 33 housewives, and we found out that after a couple of weeks, some of them could regulate temperature. And eventually, this led towards biofeedback. Gardner Murphy was there at that time as head of the research department. He was interested in muscle tension. He called it proprioceptive problem. So it was muscle tension is what it was. And he was interested in the fact that if there is an excessive muscle tension that's not under control, it doesn't do any good for the doctor to say, hey, your problem is you're too tense, because the patient is likely to say, tell me something new. They know they're too tense. Now, that's not true of all of them, because some of them say, no, I'm not. But it doesn't do any good just to be told. It's like saying, you have a psychosomatic disease. Why don't you just stop it? That doesn't work. And Gardner knew that because he had a muscle tension problem with a muscle in his neck. And what he was saying to me was, self-confrontation works in psychotherapy, so therefore self-confrontation will work in the physical domain. You get an electrode on this muscle and put it on a meter out here, and I'm positive I can get it under control. We started a project called proprioceptive feedback. And as we were talking about that, I was thinking, since we were working with housewives and temperature, it'll work in the autonomic domain just as well as in the striate domain, probably. The only reason that we work in the striate domain consciously so much is because our ancestors needed that. They were fighting with cave bears and saber-toothed tigers, and they needed to know something in the striate domain, and they didn't need to know anything about blood pressure, heart rate, and all that logistic, automatic information or stuff that was supposed to go on. Their life expectancy was probably 18 years, and it didn't make any difference whether they ever got any autonomic controls or not, because they probably didn't live that long. By that I mean they probably didn't live long enough to get very many psychosomatic diseases. Our problem is that the bears are on Wall Street and we live too long. And we all can end up with psychosomatic problems. And there's no way we can get around it because they're pounding on the door maybe 24 hours a day. And we can't just get a big rock and put in front of the door and solve the problem. And so there's no time to relax. And if people get into a chronic tension state, well, then the autonomic system gets messed up through this physiological chain. Well, Schultz, he knew that, but he hadn't done much measuring. And when we did measuring and coupled feedback in the temperature domain, then we found out that people could learn quite quickly. Well, what I'd like to do right now is suggest that you look at the temperature and see where you're starting and sit up. You have to be comfortable, but sit up in a sort of a symmetrical way so that you're not going to have any trouble with blood flow. And you can put your hands in some position so that the thermometer, so it doesn't close and doesn't touch any other part of your body or touch your hand. And you can see what temperature you're starting at. And I'll just go through an autogenic training session. And at the end of the session, you can look again to see if anything happened. You can look, of course, as time goes by, and actually in biofeedback situation, we have the meter set up, and you look, and as time goes by, you just see what's going on. I will say this, that in the autogenic phrases that I'm going to use now, these are pretty much the type of phrases that Schultz and Luthi up in Montreal, who's written the book Autogenic Therapy, these are the types of phrases they are using. And we find that the people that use these phrases use them for a couple of days, and then they start substituting visualizations, like lying on a warm beach. And it turns out that those visualizations are more potent for a lot of people than the phrases. And then after a while, then the visualizations aren't needed anymore, and it gets to the point where you just say, get warm. Like one lady that has migraine, had migraine since she was 3 years old until she was 55. She took the training program, and she went through a hierarchy of controls. She'd have to go home and lie down and endure exercises, and then she could change a 2-day headache to half a day, and then finally she could do it at the office, and she could go into her office, and in 15 minutes she could abort a headache. And then finally she could do it outside of her office if she could be quiet for 5 minutes, and now all she says when she begins to feel this change in her body that precedes migraine, she just says to the blood, go back down. And then she keeps on doing what she's doing, and she has that much control over it now. She doesn't think about it. She just tells it to go down. Well, if you want to close your eyes, you can. If you don't want to, you don't have to. I'll say the phrases. I'll say about a phrase every 10 seconds or so. You can say the phrases silently to yourself. And I want you to know that this is just the standard way in which we work with every one of the migraine patients and almost all patients that show up that have any psychosomatic problems. We start out in this way, and we do this autogenic session. And then we give them the machines, and they take the temperature machines home, and they do the same thing at home, but with the machines. But this is essentially the first kind of session that they get. The first phrase is, "I feel quite quiet." My feet are heavy and comfortable. My ankles and knees are quiet, heavy, and relaxed. My hips and the whole central portion of my body is quiet and comfortable. My chest and my arms, my hands are heavy and quiet. My neck and my head are comfortable and quiet. My face and my forehead are smooth, quiet, and comfortable. Continue with that visualization for about half a minute. My arms and my hands are heavy, quiet, and warm. I feel warmth flowing down my arms into my hands. I feel quite quiet, and my hands are warm. Warmth is flowing into my hands, and they are warm. Continue with that idea, that visualization, for about a half minute. My attention is drawn inward, and I am at ease. Deep in the center of myself, I feel quiet and peaceful. My attention is drawn inward, and I am peaceful and serene. Continue with that visualization for a few seconds. And now we reactivate by visualizing life and energy in the feet, in the knees, the hips, the chest, the head. The energy makes us feel light and alive. And then you can stretch and take a deep breath. And look at your thermometers.
The audience participants in this demonstration reported a rise in temperature ranging from 5 to 14 degrees. Here now is Oakland's Arthur E. Gladman with his experiences in applying biofeedback to clinical practice.
Any change in the mental emotional state produces a change in the physiological state, conscious or unconscious. And any change in the physiological state produces a change in the mental emotional state, conscious or unconscious. Now, contrary to the analytic approach, where in treating an ulcer, let us say, you are going to go after the emotional conflicts that underlie the production of the ulcer, instead we train the patient to control his own internal states and do away with his ulcer. And it works. And in the process, while he's doing away with it, while he's learning his relaxation, his attitude toward himself is changing, and a lot of things are changing at the emotional, mental level. And therefore, he somehow resolves the conflict, and we don't necessarily even hear about it. We just know that he has a much more relaxed approach to life, and that sort of thing. Now, in this way, we avoid the dynamics of these psychosomatic things that have been over the years so difficult to deal with anyway. You hate to see a patient with high blood pressure or ulcer coming for analytic therapy. It's just very hard work. And you know that it's going to take a while. Now, in our experience, using the biofeedback approach, it doesn't take long at all. Norma worked with 6 psychiatrists. I had a group of 6, and 3 of them are psychoanalysts. And Norma was used to seeing patients come in for 2.5 and 3 years, 2 or 3 times a week in our office. And now, if by the 4th visit something hasn't really changed with the patient, she will look at me and say, now what are we doing wrong? Or what are we leaving out? We're missing something here after 4 visits. So I think biofeedback is the best approach I know to the treatment of psychosomatic illness. And this afternoon I want to say something about biofeedback as a psychotherapeutic tool. I would not consider treating a patient on a one-to-one basis without biofeedback as an adjunct. Because biofeedback, the instrument, serves as a bridge. What I mean by that, we have a little lady who is a frail, a troubled thing who has migraine headaches. She does not communicate. She's somebody's secretary or something. I don't know exactly what she does, but her job doesn't require her to be, friendly and outgoing and so forth. And when she first started working with us, it was very difficult for her to really look at us or to talk. But here we sit. There are 3 of us in the room, and she's all wired up to the instrument, and she's doing her level best for half an hour not to think about anything, to get to the alpha or get to the relaxed state. Well, when a person is doing that, when they're really trying to be quiet, they're very receptive, or some would say hypnotizable. They are suggestible. We don't overlook this, and we make use of it to the fullest extent wherever we can. But lots of times, as with our young lady, to begin with, we have nothing to talk about. So we try to make it a social situation, a situation where the 3 of us are learning how to like each other. Our patients all become our friends. And with this little lady, this was step number 1. Now, after that happened, then she started with her continuing improvement and her control of her internal states. Then she starts to change and become more outgoing, friendly, and we've noted that many of our patients, to me only the female patients, begin to look a lot more beautiful in a lot of ways. What we do in the way of psychotherapy, I think probably is better illustrated if I talk about a few patients. On the first visit, we encourage a close member of the family, a spouse if possible, to come in with the patient. We want to see how the patient is interacting with the family. We want to get a view of the family member, but we also want the family member to leave that first hour with a good idea of what's going on. The patients find it very difficult, I think, to describe to other people what biofeedback is and what it's all about. So we're helping them to be able to do that. Now, I'm going to talk about a couple of psychosomatic cases, then I'm going to talk about cases that are primarily emotional problems. Of course, they all are, and you can't separate one from another, but I'll mention some of the techniques that we use.
This signals the end of the first half hour of your program. Dr. Gladman's remarks continue on Side B. This is Side B, Audio Digest Psychiatry, Volume 4, Number 10, continuing a symposium on the clinical applications of biofeedback. Oakland's Arthur E. Gladman continues with his account of how he uses this new treatment in psychiatric practice.
We have a patient who, while still in the hospital, a terribly tense, troubled lady with continuous tension headaches. She would squint and just, it was painful just to be in the same room with her. And we tried to train her on the electromyograph while in the hospital, and then we had her come to the office, and we gave her the relaxation phrases, and nothing happened. She kept having the headaches. And finally it became clear she wasn't practicing at home, and it was very clear, I think it was conscious to her, that she was using the headaches because she didn't like to cook, and she thought her daughter did a better job of housekeeping, and she didn't like to shop, and she was laying everything off onto the daughter. So along about the 8th visit, I said, look, this is no good. You're wasting our time. We're wasting your time. You're not practicing. Now, if you don't go home and practice this week, don't come back. She was free of headaches. Now, she does have them occasionally, but she had a clear 2 weeks when she didn't have a single headache after that scolding. And she went home and practiced. And she has changed. She's changed her lifestyle quite a bit. A patient who had renal disease was trained on all the instruments, and she enjoyed EEG training, and she became a very good alpha producer. And she used to complain when she first came to us that her hands would go into spasm when she worked in the garden. And we heard a lot about her garden. Then one morning she came in and she said, "Hey, I have a beautiful garden. I was sitting at the kitchen table looking out the window and I saw it." This is the kind of thing that happens quite frequently. I think anybody who works with biofeedback will have that kind of experience. Many of our patients who have tension headaches are at the same time compulsive. And we really don't talk about compulsive behavior. We pick it up. You can see it almost in the treatment situation. And we've had some very startling changes take place without our even mentioning compulsive behavior. A lady who lives on a farm suffered from tension headaches for years, what she called migraine, and we never argue with our patients about the diagnosis because we're going to treat them anyway. She came down for 3 days with her husband. We saw him an hour a day for 3 consecutive days, saw to it that they had a nice weekend in the city, and sent her home for 3 months to practice. And she practiced. She came back and apologized a little bit because in 3 months she'd had 3 headaches, but they didn't last very long. She wanted to reassure us. Well, when she came back, her physician came with her. The husband and the wife, the patient, the physician and his wife. The doctor came down to see what we were doing because he said it's not only that this lady is not having headaches, but she has changed. The family has changed. Well, it turns out, from the patient's own words, she said, "I discovered that I don't have to have a perfectly clean house." Well, with 2 teenage boys on a farm, I can imagine the flack that they would get from this compulsive lady. And her relationship with them and with her husband changed remarkably. But without our talking about her compulsive behavior. I'll go over to the psychotherapy side, where this is psychotherapy that's not psychotherapy, really. A gentleman called not long ago and said these ominous words: "Noises drive me crazy. I can't stand the noise. I've been moving. I've changed houses twice. I'm in a house now, but I can't stand the noise." And I thought, oh boy, here's a ding-a-ling. And actually, an extremely intelligent man, but true. His house is within 3 blocks of the freight line, and that the diesel trains do make a bit of noise. But he's reported after about the 3rd visit, well, he didn't, his wife. She called to tell me that he wasn't going to come in because he was on a trip. And she said that, boy, this guy has really changed. She said he sleeps all night. He doesn't hear the trains. And if he does hear the trains, he never moves. Now, I have not asked him how he deals with this, and I don't think I will, but I have a feeling that as a result of relaxation training, he says that he can go right back to sleep if he does wake up. About phobias, this is an example of a little bit of psychotherapy that we did with a lady who had a specific phobia, and she'd had it analyzed. She could tell you the dynamics. She could tell you the day it started, who was there, how she felt, how they felt, and why it happened, but she still had it. And it became clear that she was using this particular symptom. Her husband liked to party. He was an insurance man, and he liked people, and they were having people in all the time and going to parties. And her complaint was that if she went to a party, she was afraid her hand would shake and she'd spill her cocktail. And I finally said, "Look, Margot, if you don't want to go to parties, you better learn how to say no and forget this wiggling stuff." And she got over it gradually over a period of a few weeks, but she was feeling so much better about herself and her relaxation that she continued on with theta training for about a month. We try to, in working with our patients, to keep them in a light kind of a mood. My motto is, let's, for heaven's sakes, never take ourselves seriously. That's very bad. And we make that clear by modeling. I never wear a tie. I am relaxed. We wear relaxed sport clothing. We are relaxed in the office with each other and with our colleagues in the office, and we do not isolate the patient in a quiet room and just let them sit there. We're in and out. Somebody's always with the patient, and when there are two of us in there, we may be talking to each other, which is a kind of psychotherapy for the patient, because I will say, "Oh boy, look at that amplitude. That's great. What was it last week?" And Norma will say what it was, and it's better amplitude this week, and this is a boost to the patient. I'll talk about one more patient. This is a 60-year-old female who is built like an egg, and she is depressed, and I know her from the time that I had an office with the 6 psychiatrists. She had been seeing a friend of mine, psychiatrist, since 1953. And, you know, well, we all have, as psychiatrists, we all have patients who are growing old with us, and we're growing old together. But this woman is extremely intelligent and very questioning. She's interested in everything. And I thought we were in for a real siege, because the second time she came, she brought a letter. In letters about, well, you could hardly read it for size, and it was pages. And it was explaining why her husband was the way he was, which we were not interested in. Anyhow, he now is going to start some feedback training, and I'm not sure why. He hasn't stated what his complaint is yet, but he made an appointment, made sure that he could be seen when his wife was being seen. And his wife now doesn't write letters anymore, and she talks from a different point of view. And I don't know why, frankly. We have not talked about the dynamics of her problem. We've not talked about really anything, except on 2 or 3 occasions we have watched the myograph go up. And we've said, "What are you thinking?" Now, this is a trick that Elmer uses. He calls all the instruments truth detectors, and indeed they are. You let the patient sit for a while, and if they run into areas where there is a problem, the tension will go up. Or, if you really want to know what's the nature of the relationship of the patient to X, then you say, "Oh, how is X?" Or, you know, you bring up the subject and see what happens on the dial. This is I think, a very important aspect of biofeedback, that you can learn what sort of conflicts and problems that people are having and what bothers them, what doesn't. Because I remember one patient had been off work for about 3 months, and she was having a little problem, and she came in and she was talking about this and talking about that, and her tension was up, and then she fell silent for a little bit, and the tension went right on down. And I said, "What are you thinking about?" She said, "I'm thinking about going back to work. Isn't that interesting?" She saw it instantly, that work wasn't the place where her conflict was, and that wasn't what was bothering her. Now, I want to say that the depressed, quiet lady who wrote the letter is a psychotic depression. She has had shock therapy. I have on this list 5 people who are overtly psychotic by any standards that you might apply. They're really strange people, but they do seem to prosper, and prosper rather rapidly, from the biofeedback training. One lady was referred for pain and depression, and we haven't heard a word about either since the first interview. And she looks forward to coming, and she's happy, and she's learning to control her internal states, and she obviously is taking a whole different view, not only of herself, but of everything. And I feel this is very important, because the person develops a sense of mastery. I think everybody here has a different term for it, but we mean the same thing. They have an integrative experience. Something happens so that they view themselves not as a ping pong ball at the mercy of the external world, but as somebody who has some control. They take the fact that they've learned to control their internal state and they apply it outside. So that at times, of course, this doesn't make for a very good social relationship. We claim, with 130 patients, I think we can claim 3 divorces. And we didn't do this intentionally, but when a woman who's terribly phobic and can't do anything without her husband, and she can't ride without him, and she works in the same place with him, it's a mom and pop operation and so forth, and she's afraid to go driving, and she's afraid of this and that, and she had a different complaint every time I ever saw her, and I've been seeing her since 1949, 20 minutes once or twice a month. But nevertheless, I facetiously said, I think we have something here that might help you. And it surely did, because the first indication was that she came in one day after she was training specifically on the EEG, and she was getting down into alpha theta range and feeling very good about it. And one day she came in and she said, I was going to get nervous yesterday. And I thought about all of the things that were going to make me nervous. And I decided that it wasn't worth it. So I closed my eyes and I visualized the street, and I dumped all that stuff in the street and swept it clean. So she said, I don't have to be nervous.
Joining our panel discussion now, we'll hear Denver's Thomas H. Budzynski, and from Indianapolis, moderator Jerry E. Wesch, who poses the first question.
The question here generally deals with the question of interaction of either pain medication or other medications on patients who are coming in for treatment, how to deal with that.
They stay on the drugs exactly as they are. And they keep a record every day of all the pain symptoms and their headache characteristics, duration, etc., intensity. And then as time goes by, he gives them permission to start tapering off. And they begin tapering until finally they get down to zero. That is, in those who can get that far. Some people can't get quite that far. And that's true now also with the hypertension people that we've been working with. The cardiologists are gradually tapering off and reducing the amount of drugs that the people have to take. But it isn't a matter of just jumping off of drugs.
Even with tranquilizers, I don't encourage anybody to change their medication. And then after a period of time, 3 or 4 weeks, we might inquire, how much are you taking now, so that we get a measure of our progress. The patient will gradually cut down on his medication and then give it up. When it comes to hypertension, we say, don't you monkey with that medication except with the permission of your own physician. We encourage the patient to have his own physician. We function really as biofeedback therapists.
Here's a good question. I know there are a lot of people who are working with children and adolescents in the audience. The question is, discuss the research and applications in children and adolescents, psychosomatic responses to environmental stresses, fevers, acting out, and those kinds of things.
There's a lot of interest in that. I'm familiar with Broad and Broad, a husband-wife PhD team from Houston, Texas, B-R-A-U-D, I believe, who have worked with hyperactive kids. And I've heard of a dissertation study in which children with learning disorders, particularly, I think it was reading disabilities, were taught to produce more beta through beta feedback, and then tested after that, and they improved on their reading comprehension. There's been work in the past done with hyperactive kids in relaxation, not with biofeedback, and there are now some groups beginning to incorporate biofeedback for children. One report I read said that children below the age of 6 do not respond real well to biofeedback.
Our experience with children is that they really take to biofeedback, and they have much more rapid control of their own internal states. Apparently nobody's told them that they're not supposed to be able to do that. And the only study that I have seen is a very small study on EMG treatment of hyperactive children, which was as successful as medication. And I can't quote you the author.
Tom, didn't somebody report at the Biofeedback Research Society on a study done with retarded children? Wasn't that Steve Farian from Claremont College?
I didn't hear that, but I remember reading
it's the only one I know of, but it was with people who were retarded.
Mm-hmm. Apparently the problem that they encountered in this one study that I mentioned was keeping the children interested in practicing. It wasn't so much in the biofeedback situation, which they're delighted to do, but it's after they're out of the biofeedback situation, you try to incorporate it into their lifestyle. They seem to have some troubles with children below the age of 6.
I've got 2 questions. One has to do with positive enhancement uses of biofeedback training, essentially making normal individuals more human. The second question goes in the other direction on negative indications or contraindications or negative outcomes.
The only contraindication or negative outcome that we've ever had really wasn't a negative outcome, but it was a series of events. In the case of diabetes that I reported, when the person began to relax regularly, the requirement for insulin dropped very dramatically over a short period of time. And what can happen in situations like that is that people are, because they're still on the same dose that the physician had prescribed earlier, if they're not keeping in close contact with their physician, then they may take an overdose of the insulin. And although she was never hospitalized, there were several days when she noticed that this was happening, and then she would then call her physician, and he would say, well, you'd better lower the dose a little bit.
I'd like to say something about the contraindications. And I remember Bonnie Kaplan, when she was doing her PhD work with Tom Mulholland at the VA hospital in Bedford, Massachusetts. And she was studying the control of epilepsy, using brainwave feedback for epilepsy control. And one of the patients started developing some rather peculiar symptoms, and Bonnie began to wonder if it wasn't a toxicity problem. And so she had some more blood samples taken, and it turned out that the training program was changing the blood chemistry, and the person was overdosed by about twice on the chemicals that they had been taking for control of epilepsy. And it had been all right in the beginning, but as they did the program, they didn't need that big a dosage, and so gradually they began reducing, and the person came back to normal. In other words, if biofeedback really works, then we have to think about the possibilities of drug problems. Mm-hmm. I know Luthi ran a study with thyroid patients, just with the first two exercises, the heaviness exercise and the warmth exercise, the ones that we did today, only the way he does it, which takes 3 months to do what we did in 10 minutes. He has a very slow way of doing it. It's a real training program, and they have to go through a long time training to get all the way to the end of the warmth training. But anyway, he found in the case of people who had thyroid problems, and he was measuring both free iodine and protein-bound iodine, that those who were hyperthyroid came down, and those who were hypothyroid came up for the same exercises. And what he's saying, these exercises are pro-homeostatic. People's bodies know how to be healthy, and if they weren't messed up by their psychological correlations with physiological processes, the bodies would be healthy. So if you bring people back to a normal state of tension and relaxation in their normal lives, then whatever their problems are, and which way the homeostatic balance has been pushed, it's likely to come back towards center.
There are a series of questions essentially addressing themselves to whether or not the autogenic phrases and what we do with the machines is not either essentially a suggestion effect purely, or what people popularly call the placebo effect.
Well, it certainly is a suggestion effect, and as a matter of fact, it's interesting that autogenic training started out of hypnosis. And then Schultz gave it up because he felt that a lot of the patients weren't responding because they weren't the controllers. And so that was why he then rephrased everything in the first person. I feel quite quiet. Well, okay, is it suggestion or self-hypnosis when you ride a bicycle? I mean, what is it? And another example, if you write a letter at night and you put it in your pocket and you say, I have to mail this tomorrow. You say that, you're saying it to yourself. And then you forget it. And then the next day you're passing the post office box and then something is nagging you and you stop and you wonder, what is it? And oh yeah, I got to mail the letter. And you mail the letter. If somebody did that to us in hypnosis, we'd call it post-hypnotic suggestion, but that's the way we behave all the time in our normal lives. It's suggestion. It's suggestion and visualization. And what is the placebo effect? Well, obviously there are two kinds of placebos. One, people think they're getting better until they drop dead. In other words, it's their imagination. But the other one is the one that's connected with spontaneous remission from cancer. And I noticed that in Eric Pepper's big bibliography on spontaneous remission from cancer, that some people were going to Arizona for the grape cure, and other people were going to California to live above 10,000 feet so the negative ions could help them, and other people were going to Lourdes Cathedral, and they were all getting what in medicine would be called spontaneous remission from cancer. But the only thing all these people had in common was a change in attitude. Very interesting. They all had an attitude change. That attitude change was a limbic change, was a hypothalamic pituitary biochemical change. So that the placebo is not a nothing. It's obviously the most powerful drug there is, or they wouldn't be trying to get it out of all the drug studies.
That's a good point. The way I say it is this. Yes, of course, when the physician or when Dr. Elmer Green has a reputation such as Elmer Green has, the placebo effect has already started long before the patient gets near the Menninger Clinic. Now, if the patient is operating on placebo effect, he's also, that is helping him, in my estimation, to learn to control his own internal states. And when he learns to control his own internal states, whether or not the placebo effect was there or continues makes no difference. He has learned something.
This is essentially a more technical question concerning the extent that tension symptoms such as blood pressure, GSR, temperature, EMG, and alpha are positively correlated and to what extent are they're independent, and their variations around that. Can they be changed? Are they independent? How much can you manipulate them?
They seem to be more closely correlated at either end of the arousal continuum when you're very low, close to sleep conditions, or not including REM sleep. And then when you're at very high arousal conditions, these things tend to go together. In between, they may dissociate, and the amount of dissociation seems to vary widely from person to person. Generally, if you're thinking about lowering arousal level by using just one of the measures, you may succeed, you may not. It depends on the extent to which you actually change that measure in the direction of lowered arousal. For example, you can go through the muscle system and use frontalis EMG to pull down autonomic responses, but you have to go to low levels of frontalis EMG to do this. You could possibly use high peripheral temperature as a way of pulling down perhaps even the EMG, although there's some dissociation there too that will normally be there. That is, you may have warm hands and very high EMG, you may have very low EMG and very cold hands. So these things don't always go together. Typically what we will do is do a stress profile on the individual early in the training, and that's very easily done simply by applying a mild stressor, having them subtract sevens in their head from a number like 700 and 7 from the remainder and so on, and observe the responses, and you'll get a stress profile for that individual. And one approach is to use the biofeedback that corresponds to the most reactive response in that individual under stress.
A question on, have you ever attempted training with anybody who did not respond at all?
In the first 30 patients that Dr. Sargent at the Menninger Foundation worked with, Dr. Sargent is an internist, and he took the responsibility for the migraine patients. There were 3 people that did not respond at all, and as a matter of fact, they quit the program. They couldn't learn the temperature control, and they quit. And it was interesting that they were rigid type personalities. You got the feeling that they were not amenable to suggestion, or they wouldn't bend. An entertaining thing happened. There was a speech pathologist in the same building as Dr. Sargent, and this fellow, Dr. Bradford, heard one of the patients the day he arrived to talk to Sargent. And the speech pathologist said, after the patient had left, he said, "Don't take him. Nothing will happen with him. He's a rigid personality. He'll probably quit your program, and if he stays in it, nothing will happen anyway." And Sargent said, "How do you know that?" And he says, "Well, he has a unilateral lisp." Now, I'm not quite sure. I'm beginning to understand from a few of the things that have been happening now in the psycholinguistic studies what he was talking about. But he spotted that, and he was one of the people that just could not do anything and could not change.
One additional comment, we did our research with the muscle tension headache. We found that a certain number of people didn't respond, and these were the people who we found out later had very strong secondary gain involvement. That is, they were getting reinforced for having their symptoms, and we later in private practice ran into this on occasion and then handled it with more traditional psychotherapy or behavior therapy techniques. But generally what happens is that we find that the indication is that they don't do homework and they don't seem to respond very well in the training situation, but particularly they don't do the homework. And when that begins to happen, you can almost always find that there's some involvement there with people in their family or at work. Their symptoms are serving them well, and to give them up, to actually do the biofeedback and give up the symptom in the outside world is too much to ask of them at that point, because they do not have adequate coping skills to take the place of having the symptoms and thus avoiding these situations.
There's another question here. I have specific interest in treating a case of amyotonia congenita in an 8-year-old girl. There is complete volitional control of all skeletal muscles and apparent autonomic smooth muscle control. However, no background muscle tonus is present. This is also known as floppy baby syndrome. Is anyone doing specific work in this area of increasing tension or tonus?
Well, actually, Tom has had a lot more experience than probably the rest of us on working with EMG for increasing muscle tension. But I do know that Dr. Brudney out at ICD, it's a rehabilitation center on Manhattan Island. It's connected with the New York University Medical Center. It's a private foundation, though. It's a private nonprofit foundation for rehabilitation. And I met him about 4 years ago, 5 years ago now, and he said that they had 1,500 patients with striate problems. And they ranged from polio victims to paraplegics to torticollis patients. And a lot of it had to do with muscle tension increase. And especially, for instance, in torticollis, which is wry neck. People's heads might be diverted to one side and they can't move it back. And if it's over on the right, he'd teach them to decrease the muscle tension on the right and increase it on the left. They move the electrodes from one spot to another and give them alternate training. And what he told me, of the 42 torticollis patients, they'd had, I think, complete success with about 30%. Partial success was 30%, and some of them had to have continuous training, like every day they had to be trained in order to maintain it. Those that had complete success, after a few weeks, they were okay, and they didn't have to be trained again. Partial success was they'd have to come back every 3 months or so and have some retraining. And he mentioned, incidentally, that these were the people that didn't respond to any drugs, and they were the ones that the psychiatrists were saying, please don't send me any more torticollis patients.
A question here is more details on the stress coping program, which Tom had talked about, and also on weaning people away from the machines and the tapes.
Yeah, the stress program is taken a bit from behavior therapy and does involve a certain amount of relaxation training combined with biofeedback to refine the technique. And then the final stage is one in which the individuals are taught to do what is essentially a systematic desensitization, except we call it stress management because that's more acceptable to people that don't like, as they put it, shrinks, and so they prefer to think of themselves as learning to manage stress rather than some esoteric term connected with clinical psychology or psychiatry. So they have now learned to relax and produce this cultivated low arousal, and they then, given that physiological background, they imagine themselves in a number of stressful situations specific to their own life and see themselves as performing competently and adequately, and practice also the positive self-statements that go along with the control, such as, I can control, I can relax, I can handle this situation. That's a new area of behavior therapy which is looking very strong, the shaping of cognitive self-statements, getting the person to stop saying negative things to himself and to begin saying positive things. And when you combine that with the physiological control that biofeedback can give, then you have indeed some very powerful coping skills that you've taught the individual.
The Audio Digest Foundation thanks the speakers and the Indianapolis Community Hospital Mental Health Center for their cooperation in disseminating this material. Your next issue, Doctor, from the just concluded meeting of the American Psychiatric Association, the beginning of a series of selected highlights, leading off with a panel on sex therapy featuring William H. Masters, moderated by Helen Singer Kaplan. Audio Digest Psychiatry is a bi-weekly service of the Audio Digest Foundation, a non-profit subsidiary of the California Medical Association. This tape is copyright 1975.